Great pleasure for me to be part of this exciting program in the World Ophthalmology Congress. I have no financial interest in the topic that I'm going to talk today. Intraocular pressure is the main and only modifiable risk factor in glaucoma. However, complete pathophysiology of glaucoma is still unknown. Many genetic and environmental factors may influence development of glaucoma. We know multiple non-IOP related risk factors: non-modifiable age, gender, genetic predisposition, race, refraction, and also modifiable as systemic hypertension and hypertension, vasospasm, migraine, and others. We have growing evidence that lifestyle habits may influence IOP and ultimately outcomes of glaucoma. On the other hand, patients are becoming increasingly knowledgeable and we want to take active part controlling their disease. So it is important to raise public awareness about lifestyle habits affecting glaucoma management. Blood pressure is the main systemic risk factor and is well known in the development of glaucoma. Benefits of treating systemic hypertension are clear, but we need to avoid overtreatment because thorough studies have shown that both ends of blood pressure spectrum are damaging. Too low diastolic blood pressure and too high systolic blood pressure are leading to optic nerve damage. In ophthalmology, we have multiple cross-sectional and longitudinal studies that have shown that low ocular perfusion pressure is the risk factor in the prevalence, incidence, and progression of glaucoma. Glaucoma doesn't sleep. IOP is highest at night, and it has been shown that sleeping with 30 degrees head-up position may lead to IOP lowering. But it is important to elevate head and chest together because bending too much the neck leads to venous compression, episcleral venous pressure rise, and choroidal vascular engorgement. Obstructive sleep apnea is another problem leading to increased risk and worsening of glaucoma. Obstructive sleep apnea may cause cardiovascular dysfunction, hypertension, damage to the vascular endothelium, increased episcleral venous pressure, and diminished aqueous outflow. And the end is increased risk of glaucoma progression. The good thing is that greater physical activity is associated with slower visual field loss in glaucoma. It has been shown that additional 5,000 steps or 2.6 hours a day of physical activity may decrease the rate of visual field progression and damage by almost 10%. So the physical activity may be marked as a novel modifiable risk factor for preventing glaucoma damage. Other studies have shown that at worse levels of visual field damage, the patients show lower physical functioning. It is the question whether it's a cause or effect for progressive visual field loss and restricted activity. Not all kinds of sports are equally beneficial because we know that head-down position is leading to higher hydrostatic pressure and also may lead to transient rise in IOP. It is not a problem in healthy subjects or a short rise in IOP, but if we have wind blower instruments performing activities with sudden head movements, this might be quite risky in glaucoma patients, should be avoided or at least taken into account. How do we need to sleep on which side? So lateral decubitus position results in rise in IOP in the lower eye. But cardiologists have shown that right atrium is in lower position when patient is lying on the right lateral decubitus position. Then we have easier venous return to the heart and lower intraocular pressure. Stress does not cause glaucoma, but may significantly affect management of glaucoma. It may increase the intraocular pressure, and anxiety also increases the risk of glaucoma progression and maybe even associated not only with the rise in IOP, but with hemorrhages as well. Stress enhances the rise in endothelin 1, leading to vasoconstriction and transient myocardial ischemia. Then we have the question of meditation, whether it's beneficial. Of course, Tanush Dada group has shown that mindfulness meditation is associated not only with a significant decrease in IOP, but also with the changes in trabecular meshwork gene expression, indicating direct impact on ocular tissues. So if we know that oxidative stress is causing optic nerve injury, the question is whether we have potential antioxidative effect in nutrients. And this might be explained that nutrient molecules containing antioxidative effects may donate a proton or withdraw an electron, and by this they neutralize the free radicals. So fruits rich in antioxidants may offer neuroprotection. The other studies show that dark leafy greens may contain nitrates that are converted to nitric oxide that leads to vasodilation, increased outflow of aqueous humor, and decrease in episcleral venous pressure. The benefits of coffee, tea, and wine are clearly not fully estimated, but we know that the source is in polyphenols. They inhibit lipid peroxidation and probably even may show some kind of effect on the mutagenicity. Marijuana is questionable. It leads only to transient lowering of intraocular pressure for 3-4 hours, and due to short duration of action and side effects, it is not recommended in glaucoma. Omega-3 fatty acids have shown quite good effect improving ocular health, especially retina. And in glaucoma patients, it may likely lower the glaucomatous optic neuropathy by increasing ocular blood flow and decreasing intraocular pressure. But other studies showed the other way around, that it may even increase the risk of glaucoma. So benefit, it is still controversial. The dietary supplements results are conflicting and inconclusive. We want included vitamins as part of healthy diets. There is no other evidence to support specific vitamin supplementation in reducing the risk or treating glaucoma. But vitamin B3 has been shown to be preventing mitochondrial dysfunction in mice, and in humans it may improve inner retinal function. So it is still under investigation. Ginkgo biloba is known for 2,000 years, but it is still inconclusive because it may lead to increased blood flow and improve even indices in the visual field, but the definite conclusions are not driven. So, in conclusion, it is worth exploring modifiable glaucoma risk factors other than IOP to control the burden of glaucoma. Current evidence is not sufficient to make strong recommendations regarding lifestyle or dietary supplements, but the rule of thumb is that everything should be done in moderation. Thank you for your attention.
Dear chairpersons, dear colleagues, thank you for the kind invitation to give this talk about burden of glaucoma. My main disclosures have always been Finnish taxpayers. In addition, the government ecosystem that I have developed is supported by Finnish government organization. European Glaucoma Society defines its vision as gaining outcomes with minimal visual disability, best possible well-being within affordable healthcare system, affordable to glaucoma patients, citizens, and the society. From a global perspective, this cartogram shows how far we are from the vision, especially in developing world. Trying to solve the global imbalance by copying the very high density of ophthalmologists in developed countries into the developing world is not meaningful. As the system is too expensive even for us, it cannot be transferred into developed countries. Namely, although the Western countries spend more money on healthcare and produce more services than ever before, and the citizens are healthier and live longer than ever before, simultaneously demand of services and costs continue to increase exponentially. Also, the reasons for blindness are different in the developed and developing worlds. For example, in Finland, the three giant AMD, glaucoma, and diabetic retinopathy cause permanent visual disability, but no patients are blind because of cataract. In addition to glaucoma, we need to consider all big four eye diseases. This slide shows how the number of AMD treatments has increased much faster compared to the three other eye diseases. As the overall resources in Thai's eye center have not increased to the same extent 19-fold. This means that we will have less money for other eye diseases. It is also important to pay attention to variabilities. In one university eye clinic in Finland, the increase of AMD injections was much less, 10-fold, while in another one, the increase was 25-fold. It is obvious that all cannot be right. In 2015, EGS evaluated the biggest challenges in glaucoma care, which were the same in different parts of Europe. Number one was increasing demand. Number two included both under and simultaneous overcare. Overcare obviously influences both the increasing demand and non-optimal use of resources. Large variability is a well-known reality. In spite of the evidence and guidelines, also in glaucoma. In addition, the latest update of the EGS guideline, an overview of systematic reviews, found a high decrease of uncertainty also in evidence. No wonder that when the outcomes of RCTs, efficacy, are implemented in everyday practices, the variability will be even larger. In patients with several comorbidities, variable experience of caregivers, and so on. In addition, in real world, patients have two eyes compared to the one-eyed patients in RCTs. Therefore, it is crucial that we need to learn how our patients are seeing and doing under our everyday care, both at patient and system levels. When collecting routine real-world data, automation, full coverage of data, single data entry, and easy-to-read output are crucial when comparing data between units. In addition to demand and productivity, and in order to evaluate cost-effectiveness, we need to have data on outcomes in real life, quality of life, and costs. In our Finnish ecosystem, we use general health-related quality of life instruments to measure well-being. And this instrument has a question for vision. 15D separates the different groups from each other: general population, glaucoma, AMD, and visual disability. Last but not least, as all impacts, good and bad, in healthcare, as well as all costs, arise from our decisions, we need to start thinking and doing things differently. Obviously, big data requires big thinking. We need to learn whether we are doing good enough job in our glaucoma care and eye care. The only way to do that is to collect data on what we are doing in our everyday clinics, and then compare our outcomes with other units nationally and internationally. Thais Eye Center offers its real-world data collected since 2008 in more than 12,000 glaucoma patients for benchmarking. We want to know whether we are doing good enough job in our glaucoma care, taking care of our patients. Thank you very much for your attention.
Thank you for joining us for this virtual World Ophthalmology Congress session. My talk is titled Glaucoma and Real-World Disability, and my name is Pradeep Ramalu, and I'm a professor of ophthalmology at Johns Hopkins Wilmer Eye Institute. Here are my disclosures regarding these talk. Well, when we talk about real-world disability, what do we mean by the real world? This is a definition of the real world which talks about the existing state of things as opposed to one that is imaginary, simulated, or theoretical. When we talk about disability, we often talk about something which is simulated or maybe theoretical. But when you talk about what is real world, is it what the patient perceives, or is it simply how the patient lives, behaves, and functions? I'm going to argue that it's both. This is a model of visual disability put forth by myself and Bonnie Sweener in 2020, which talks about disability as one of several health outcomes. And we can understand that obviously by what the patient feels, also by how they function, which is a very strong predictor of disability, or by other factors which contribute into disability, such as vision, but also personal factors and environmental factors as well. So when we talk about reality, there's really kind of two levels of reality, what the patient perceives and what is actually happening to them. And even when you talk about self-report or what the patient perceives, is that really all of reality? If I was really going to capture glaucoma-related disability fully, I would want to know not only what the patient believes, but also how glaucoma affects their family, society, and us as providers as well. This is a model for that put forth by Simon Skalicki in Journal of Glaucoma in 2019. Of course, obviously, what their disability is and what happens to not only them and their family and society is related to what actually happens to them, how they're actually functioning, not in a lab environment, but in their native, non-idealized environment. Or if you have to do a task in something which is a close replication of that task. And obviously these tasks should be in things that are important to the patient. There's certainly quite a bit of work that shows that glaucoma influences self-reported quality of life. This is one of many papers on the topic which we did using a quality of life outcome measure. And we found that several measures of vision, actually interestingly most strongly contrast sensitivity, was associated with quality of life in glaucoma. And this really captures quality of life just about as well by itself as it does even when you include 2 or 3 measures of vision. There's certainly some work on patient function, on patient disability, which extends into caregiver burden and quality of life as well. And this is a very nice work by McDonald and David Crabb, which show that patients with advanced visual field also tended to have worse quality of life in their informal caregiver, and also showed that there were associations between the patient's disability measures, or the EQ-5D score, and a measure of caregiver burden, the MSCI. Well, what about objective disability? This is one study we did looking at silent reading, which is a much more relevant task than out loud reading, which is usually something which we do only for short periods of time. And we found that glaucoma was much more associated with silent reading over longer periods of time than it was out loud reading. It was also associated with worse comprehension. We also found that reading speeds decreased over time in glaucoma patients, but not controls, suggesting that it may have a particular difficulty with prolonged reading, which you might need to do for a job or for leisure, such as pleasure reading. We also found that glaucoma severity was associated with changes in multiple types of behavior. So for example, this is one study from the Salisbury Eye Evaluation, which found a higher probability of driving cessation with more glaucoma damage in the better seeing eye. People who have worse vision from glaucoma also tend to restrict their vision as well. This is one study we did, showing that the odds of not driving and the odds of driving limitations were elevated as your visual field or contrast became worse. And this replicates work by Alex Bowers and others back in 2005. If you restrict your driving, it stands to reason that you might also travel outside the home less, and this is indeed what we found with the GPS tracker in glaucoma patients who are about twice as likely to not leave their home on a given day. And obviously, if you don't see well, you might also restrict your physical activity, and this has been shown by us and others. And this is one paper which showed that individuals who had worse vision in their better seeing eye took fewer steps over the course of the day. In those who continue to stay active, either by driving or walking, it poses a greater risk to them. So driving has been shown to be more risky in glaucoma patients. They have a higher per mile crash rate as their vision gets worse. And if you look at them as they perform on the road, their on-road driving is also worse. Visual field damage from glaucoma also leads to higher fall rates. This is particularly true when you look at the rate of falls per step taken. So this is a study which showed that the rate of falls per step that you take was higher in glaucoma patients, both within the home area as well as away from the home area. So simply staying in a more familiar region does not solve the problem. It is notable that falls away from home are likely to lead to an injury. So both of them are important and need different solutions. You should be thinking about disability not only in terms of the person, but in terms of their other aspects of their life as well. This is one study that we submitted for publication. It showed that people who are living in more impoverished areas or areas with greater deprivation are also more likely to do less physical activity, which is one measure of disability. We also found that there was interactions between their deprivation measures, ADI, poverty share, or crime rates, and how much they restricted their activity. So if you look at some specific measures, you see that patients with severe glaucoma, which were much more affected by crime, are much more affected by poverty than individuals with mild damage. Well, what about the environment? Not only is it the neighborhood that you live in, but within the home, there are hotspots for disability measures such as falls, and areas such as the bathroom, stairs, and bedroom are areas where people fall more often. And these areas may be hotspots because they're more hazardous, and we did, when we looked into the homes of patients with glaucoma, find that there were a greater number and percentage of items that were hazardous in these regions. Well, what about do these areas matter? While hazards were not associated with a higher fall rate in our study, we did find that better lighting was associated with fewer falls, suggesting that the environment may be a modifiable way to prevent aspects of disability. And so one recommendation we do have for people is to increase lighting to 300 lux or more. Patients do not alter these issues. So for example, we found that regardless of their level of damage, they had the same number of hazards within regions of the home, and also that they had the same level of lighting. So our take-home message is that patients are affected by their disease outside the clinic in the real world. And this is just not confined to the patient, but others such as their caregiver and families and society as well. And disability should not be purely viewed as a function of poor vision. Other factors matter too, such as the social situation of the patient, as well as their lived environment. Thank you.
Good morning. I'd like to thank the organizers of the WOC for inviting me to give this talk on how to detect genetic associations in patients. I'm sorry I'm unable to join in person or online as I'm traveling. I have no relevant disclosures. When would you suspect a disease to have a significant genetic contribution? Well, if you look at the pedigree, for example, you have some clues: early age of onset, enriched in either sex, enriched in some ethnic groups, strong family history, greater sibling risk, or all of the above. And in our practice, we often find families with inherited diseases. And in such categories, what questions would you ask? Firstly, look at the age of onset, look at the sex, look at how the disease runs in the pedigrees. Is it a Mendelian inheritance, autosomal dominant, autosomal recessive, or sex-linked? And you want to answer the question, do the affected individuals share a piece of DNA that unaffected individuals do not share? And for such approaches, you need to do something called genetic linkage studies. And these require large pedigrees in which there are both affected and unaffected people, preferably in multiple generations. In linkage analysis, the principle is to find a genetic marker which is completely shared among affected individuals and not with unaffected individuals. And for linkage analysis, there is a statistical test called the LOD score, or logarithm of odds score, and the greater the LOD score, the more likely it is significant. And the cutoff is use of a LOD score of more than 5.0, as this example of breast cancer with BRCA1 mutation. This is a large pedigree of open-angle glaucoma identified with linkage analysis to chromosome 1q21, and subsequent studies identified this genetic locus to be mycilin, the first gene identified for open-angle glaucoma. Apart from linkage analysis, you can also perform whole exome sequencing or whole genome sequencing in pedigrees. Again, you have to compare cases of affected versus unaffected. But such approaches are more costly with more data required to analyze these pedigrees. For most adult onset diseases, the genetic approach is different. In adult onset diseases or age-related diseases, the genes responsible are not like Mendelian disorders. They are not single gene disorders, but they are genetic risk factors which contribute to the disease risk. And for these approaches, you would perform something called a genome-wide association study, or GWAS. In the GWAS, you are comparing cases versus unaffected, and you run markers called single nucleotide polymorphisms across the genome of at least 2,000 to 5,000 people who are affected compared to those who are normal. And in this is the output of a GWAS study called a Manhattan plot, because it looks like the towers of Manhattan. And imagine each dot represents a SNP, and the taller the tower, the more significant the association. So here you can see a red line, and this is the cutoff of 10 to the power minus 8. So the p-value must be less than 5 to the times 10 to the power minus 8 to be significant. GWAS is a powerful approach to identify low penetrance common genetic variants that contribute to complex diseases such as glaucoma or age-related macular degeneration. Remember, GWAS studies identify genetic risk factors, and typically the odds ratios are normally between 2.0, so between 1.1 to 1 to 2.0. And the p-value of significance, as I mentioned earlier, is 5 times 10 to the power minus 8. This is what a GWAS chip and platform looks like. Nowadays, you can perform a GWAS within hours. The first ever GWAS was actually performed for age-related macular degeneration in 2005. In only 96 cases and 50 controls, they identified complement factor H to be associated with age-related macular degeneration. Since then, there have been many GWAS studies for AMD and glaucoma. For example, in this paper, they identified 68 loci for intraocular pressure and primary open-angle glaucoma. In 2019, our group performed a very large GWAS in patients of African descent and identified another gene for POAG in Africans. And the most recent GWAS for POAG in 2021 identified more than 127 open-angle glaucoma loci. And just in open-angle glaucoma, we performed GWASs for angle closure glaucoma as well as exfoliation glaucoma. What are the issues with GWAS? Well, firstly, is sample size. So the smaller the effects, the larger the sample size required. So for example, if a GWAS hit has a odds ratio of 1.2, you need at least 4,000 cases and 4,000 controls to identify those genes. Another problem with GWAS studies is the phenotype used. Often we pool the phenotypes of patients. For example, we call them open-angle glaucoma or angle closure glaucoma or age-related macular degeneration. However, we also know that there are often subphenotypes, and if you look at more defined subphenotypes, you may find different genetic bases for these diseases. Another limitation of GWAS is that the signal or the genetic marker is only a surrogate of the functional gene. In that area, there may be several genes that could be the responsible gene that's associated with disease. Another problem is that GWAS hits often are in intronic regions which are non-coding, and so they are not regulatory mutations as such. With advances in technology, we have now moved on from GWAS to whole exome sequencing, where you are trying to identify rare mutations of high penetrance and high risk that are often missed by GWAS. In whole exome sequencing, you are only sequencing the coding regions of the genome. And here you're looking for rare variants which have high penetrance. As you can see this example of loss of function mutations in LDLR that confer 13-fold risk of acute myocardial infarction. Our group has recently performed whole exome sequencing for exfoliation syndrome and identified rare variants in a gene called CYP39A1 with risk for exfoliation syndrome. With further advanced technology, we will also be soon performing whole genome sequencing, and this requires even more data to analyze and is more costly than currently available. What is the role of clinicians in all this work? Well, the clinician plays an important role, firstly in precise phenotyping. It's very important to determine who are affected and who are normal. We need to look for the gold standard diagnosis. Physicians often need to perform genotype-phenotype correlations to look at how the disease course varies with different genetic mutations. We also want to see whether genetic risk factors compare to traditional risk factors for screening, does it increase predictive value or clinical utility? And we want to understand disease biology better, how the genes are involved in disease biology, pathways as well as the effect on disease phenotype. So in summary, there are many approaches to investigate the genetic basis of diseases. For pedigrees, we perform linkage analysis as well as whole exome sequencing. and for complex traits, we perform GWAS studies or whole exome sequencing. Thank you for your attention.